Hello and welcome back to the channel. It's early August 2023 and every early August there's a huge shift of all the junior doctors around in the UK's NHS when junior doctors start fresh from medical school and all the other ones move around. It's like a big national game of musical chairs. And it's also the 20th anniversary of me qualifying as a doctor. I qualified in August of 2003. So in this video, I thought it would be useful for me to share 20 top tips from 20 years as a doctor, 10 plus of them as a consultant surgeon that hopefully you will find useful. These are all tips that were some sort of personal rules of mine to avoid mistakes, things I've picked up along the way, and also lots of it stuff I wish that somebody had told me when I was a junior doctor in my 20s. So with that, let's get into it. The first thing to say is congratulations on having qualified and welcome to the profession. Tip number 1. Never put anything into a patient unless you know exactly what it is. So I have a few rules for myself that have stood the test of time and have stopped me making mistakes, and this is one of them. I never ever put anything into a patient unless I knew exactly what it was, unless I had either drawn it up myself or watched somebody draw it up in front of me. This is particularly important in the case of an emergency, or if, for example, you're tired or hungry or there's some sort of time pressure involved. And because obviously the consequences can be quite catastrophic. You can put the wrong drug into a patient, the wrong dose, the wrong amount, and so on and so forth. Because you will be involved in emergencies and somebody will hand you something and you're tempted to just push it into the patient, and it's worth taking a moment just to see what it is. Is it the right drug, the right dose, etc. Tip number 2, always check the x-ray and the path report details first. So again, you will be reading blood results, x-ray results, scan results, and test results, pathology reports. So I always checked before reading the conclusion or the results and interpreting it and making a decision based on that. I wanted to make sure that it's the right one, so I always check the patient's name, date of birth, and the date. In other words, am I talking about the right patient at the right time? Tip number 3, don't ever lie or ever shade the truth. Now, of course, this is not me saying that people are liars. Most people, especially in healthcare, are good, hardworking professionals doing their best, often under difficult circumstances. But if you're ever tempted to cut corners, shade the truth, remember that the notes you make are legal documents. I never appreciated this when I was a junior doctor, but having been a consultant now for 10 plus years, sometimes you go back on the records, on the patient's notes. For example, if there's a medical legal case, it's really important to go back and have good records of everything. And you don't appreciate that because as a junior doctor you kind of pass through different hospitals on different posts. But if you've been a consultant and you see stuff like this, you realize how important it is to make good, accurate records, and the fact that these are legal documents. Sometimes they're actually brought up in court cases, so always remember that what you write in notes are legal documents. I guess the kind of message of this tip is that I never did anything or never made a decision that I couldn't justify before a panel of my peers. So forget about journalists and managers, but a panel of your peers, a panel of your fellow doctors who know what you do and so on. I never did anything that I couldn't justify before a sort of imaginary panel of my peers in my mind. And of course, there are a lot of formal systems in place to pick up any problems that might be an issue, up to and including the GMC, which can stop doctors practicing as doctors. And in fact, another top tip here is always to keep an eye out on the MPTS website. This is a publicly available website. You can go to it right now. And it's basically the GMC's website for tribunals and issues with doctors who have gone up before panels of their peers. And it's a very instructive and very sobering thing to spend a bit of time on this website, because you realize kind of what other doctors get done for, and so you can avoid them. Tip number 4 is have to versus get to. So this is a shout out to Ali Abdal, who's a very good YouTuber. He's a former doctor And he learned this, I think, from a chap called Seth Gordon, who's a famous blogger. And essentially, it's about a mindset shift. So there will be times, there'll be loads of times when you will feel frustrated, tired, doing tedious jobs repetitively, where you think, oh no, I have to do this thing again. But if you change your mindset from I have to do this thing to I get to do this thing, it changes the sort of, it changes the weather, it changes the way you look at that issue. I remember this when my son was born, and you know, when you get up in the middle of the night or you have to change nappies and so on, and I can tell you, once you've changed about 50 nappies, the 51st time is less cute and interesting. And so I used to kind of change my mindset by saying I have to do this to I get to do this. It's actually a privilege. And don't forget that being a doctor is actually a great privilege. You get to meet people of all sorts. You get to meet people often at a very tricky time in their lives. And one thing is very important to remember is that people remember what doctors say to them. People remember how doctors make them feel. Now, tip number 5 is about nurses. Nurses can be great allies for you. They can make your life a lot easier than it would otherwise be. They are our fellow hardworking professionals doing, what is, it's a tough, thankless job, often for very little pay under great pressure. One of the tips I had, one of the rules I had for myself when I was a junior doctor is every night before I called it a day, I used to do a sort of mini ward round just for myself and approach each individual nurse on the ward and say, is everything all right? Is there anything you want me to write up? Any drugs, any fluids, anything like that? And I used to all the patients tucked up in bed and make sure everybody is happy before I went. This was obviously for my own benefit to stop needless bleeps, but also they really appreciated that, the fact that I was kind of willing to do that, and the fact that they felt that I was making their lives easier as well, because I wanted to sort of nip problems in the bud so that they would have a quieter night too. The other thing I always used to have a habit of doing is that if somebody called me with an isolated number, so an observation, for example, a blood pressure, the patient's blood pressure is 90 over 60, I never went by that number alone, because that's just a snapshot. Remember, in medicine, the trend is your friend. So patterns are important more than isolated numbers. And so I always used to ask the nurse, what are the 3 previous obs? Or if it wasn't urgent, as it often isn't, I always used to ask them to do a fresh set of obs to see if a pattern was emerging here, rather than just an isolated number. Because remember, an isolated number can be this point on a graph going up, or at the same point on a graph going down. So, you need to know that to be able to assess the situation and what to do about it. This also had the added benefit of creating a little bit of friction for the nurses, and after a while they got to know this, and so they wouldn't just call me willy-nilly with a number and then say doctor informed, and that was that. So it created a little bit of friction, so that they did a little bit of work beforehand, and their calling me was a little bit more intentional. Just ask a couple of pertinent, reasonable, non-controversial questions. Again, partly because it's important to know that, but also because it created a little bit of friction. And after a while, the nurses get to know you once you've been working with them for a few weeks and months. And then they kind of know that you're going to ask that, and therefore they did a bit of work, and therefore it kind of cut down on the number of random emissions of bleeps. But just remember, nurses are fantastic colleagues. And again, if you have 10-15 minutes, nothing is happening, offer to make them a cup of tea. It just creates a goodwill and a sense of camaraderie, because we're all in it together, and most people are good, most people are trying to do their best under difficult circumstances, and we're all in the same boat together. Tip number 6 is about letting patients know what they're about to feel. So this is a little bit about just a common sense and a sense of common humanity, I guess. So you all remember from medical school having been taught to, when you palpate the abdomen, when you examine the abdomen, to do it lightly first, and then to do it a bit more deeply, to check for organs and so on. But obviously, just before you do that, to let the patient know, I'm going to palpate it, I'm going to press a bit deeper now, so that the patient knows what to expect. This applies in all sorts of other areas of your work. So for example, common example, if you're just about to put in a Venflon or take some blood, let the patient know that they're likely to feel they will feel a sharp scratch, so that it's not a surprise to them. Similarly, if you're, putting the bed down or up or sideways or whatever it is, let them know that this is just about to happen, so that it's not a surprise to them. Remember, a lot of anxiety for patients, and quite often if you put ourselves in their shoes, patients are very anxious. They're often having a very bad day when they come to hospital. They don't know what's happening. They don't understand what's happening to them. They don't understand what's being done to them. So a little bit of common humanity, putting ourselves in their shoes and seeing the world from their point of view and saying, this is what's happening, this is why it's happening, and this is what you're likely to feel. I always do this as a habit, and it's become a Pavlovian response in me. So you're just about to feel this, and then if they feel that, obviously it's not a surprise to them, and thereby allaying a lot of their anxieties. Tip number 7 is get to know your payslip. Now in America, these things are called paychecks, but once a month when you start work, and for a lot of you, this will be the first time that you will have been in sort of responsible paid employment on a sort of consistent basis. Now you will get a payslip every month, and it's really worth, first of all, keeping this, downloading it, or if it's in a paper format, scanning it and making sure that you keep it safe, understanding what your gross payment is, understanding what your net income is, understanding your pension, understanding how much is being deducted and if that's correct. Quite often when you start a new job, your tax code is incorrect, and you have to keep an eye on stuff like this, because systems misfire sometimes and mistakes are made and you get underpaid. Very often underpaid, you hardly ever get overpaid. There are 2 other documents which are worth keeping track of. One is your P60, and your P60 is a summary of the tax you have paid for each tax year. Each tax year in the UK starts on the 6th of April, ends on the 5th of April, and by the time the system generates it, it'll be sort of late April, early May when your P60 is generated. It's really important to get that and to keep it. And the other one is something called the ABS, or the Annual Benefit Statement, which is to do with your NHS pension. The NHS pension is a very, very valuable part of your remuneration. A lot of people in the private sector would love to have the pension scheme that you and I have, and therefore it's very important to keep track of it, to again correct any mistakes that the system may have made, and that usually comes out late August, early September each year, and there's a website that you can download that, so make sure you do that. If you want me to do a separate video on financial literacy for junior doctors, let me know in the comments below. Tip number 7 is always take the stuff you need for a procedure to the patient's bedside, so that you don't make repeated trips back and forth. So if you want to take blood, or if you want to put in a Venflon, or if you want to put in a catheter or a chest drain or whatever it is, spend an extra 5 minutes gathering all the stuff that you need, and then take all of that to the patient's bedside so that you don't have to run around. This happens all the time, and remember, efficiency is not about being fast, it's about fewer wasted minutes, about fewer wasted journeys. So this is another one of those rules I had for myself. Every time I wanted to do something, I put in a Venflon or whatever it was, as you'll be doing many times during your year as a junior doctor, I always used to spend an extra 5 minutes to save me 10-15 minutes down the line. It was about being efficient, not being about fast. Tip number 9 is have a little file or a folder on your phone or iPad entitled Interesting Patients or Interesting Observations. One thing you'll find is when you start work as a junior doctor, it can be quite overwhelming and everything is kind of happening fast and in a blur. But there are certain things you see, certain patients you meet, certain situations you encounter that are really kind of, they merit further thought and reflection. I still remember a lot of the patients I came across in those days and what I learned from them. You learn from everybody all the time, and it's worth kind of having a sort of folder somewhere. Obviously it has to be anonymous, and you mustn't have any patient confidential stuff in your own personal system, but stuff that merits further reflection. And it's always a good idea to, especially if you've had a long day, if you had a tough day, if you've been in a very difficult circumstance that you haven't encountered, as will happen to you all the time. As a junior doctor, you'll be veering outside your comfort zone on a daily basis, certainly to begin with. It's always a good idea just to make a note of it, reflect on it, review your day, review the situation, because a lot of the learning can happen. Some of the learning can happen in the moment, but a lot of the learning can happen also when you review it for yourself or over a coffee or a pint with a colleague afterwards, especially if something bad has happened. So if somebody dies on you, or somebody dies in a horrific way, or something is upsetting you, or you have encountered a situation that is very much outside what you used to, it's always a good idea just to kind of jot it down, reflect on it, review it, and learn more from it than would otherwise be available to you at that acute moment. Tip number 10 is the consultant's view of junior doctors. So I've been in both positions. I've now been a consultant surgeon for 10 years plus, and the old adage still applies. I remember this adage about the best junior doctor is the one who is the 3 A's, who is available, affable, and able, and in that order. And that's actually generally true. Now remember, consultants are just people. There are busy people. Especially consultant surgeons have been kind of portrayed generally as being very irritable and very irascible. But most people are just people. They're doing a difficult job, and I can tell you that consultants are very busy people. They've got a lot of spinning plates. I like to think of it as they have a lot of browser tabs open. They're dealing with, I don't know, their children's school, or their mortgage and their ingrown toenail, or the difficult colleague at work that they have to navigate, and the next stage in their career, stuff that everybody else is dealing with, I guess. And so think of it in that way. Think how can you make the job of your consultant easier. The best way I thought about this when I was a junior doctor, and this was explained to me by someone, and I think it's still a very good way of thinking about it, is the junior doctor is the person that turns the consultant's thinking and plan into kind of action and reality at the coalface. So that's the best way of thinking about it. And tip number 11 is kind of related to that previous point. And the tip is always remain open to feedback and to criticism even. In other words, remain teachable. One of the things about young people, and I may sound like an old fuddy-duddy here, but a lot of senior people are worried about providing feedback to younger colleagues because they're afraid that this person might kind of take it the wrong way, or might be a bit fragile, or might be a bit prickly and kind of misconstrue well-meant advice, guidance, criticism often as take it the wrong way. And if you have this kind of approach of being open and being teachable, you can actually get a lot out of your senior colleagues, because then they have a lot of advice to give you, they have a lot of feedback to provide you. I mean, I learned a lot from my senior colleagues just by watching them, by osmosis, just how they carry themselves, how they talk to patients. This is the kind of stuff that you often, I'm afraid, are not taught at medical school, because a lot of medical school curriculum is provided by non-medical people, but you can learn a lot by just watching and also asking for, if you have a question. So remain teachable, I guess, and this applies to all of us. I'm very teachable. I learn from everyone all the time. That's my general approach to life. Tip number 12 is develop an intuition, a sixth sense for the sick patient. Remember, patients who come into hospital don't come labeled with a diagnosis, and sick patients often don't have a label on their forehead saying I'm about to go off. And the other thing to remember is that a lot of your patients are elderly, especially if you work in a medical specialty, and elderly patients sort of generationally and temperamentally, they don't complain. They don't like to make a fuss, they don't like to bother the doctor, they don't like to complain, and so therefore you need to have a sixth sense, sort of intuition about when a patient is about to go off. And of course you should listen to staff who are experienced, whose instincts you trust and respect, who have been around and have been in contact with that patient, and who tell you that I'm not happy about this patient, something may not be right here, you better come and see the patient. Always listen to that. And I'm not talking about some Jobsworth who's kind of ticking a box on a protocol, but actually somebody you respect and trust their instincts. And if somebody says that about a patient who might be going off, never ignore that, and always err on the side of doing more and reacting earlier if you feel that somebody is going off. Tip number 13 is always check to make sure somebody's not allergic before you prescribe them antibiotics. I'm dating myself here a bit, but in the old days when we used to write prescriptions with pen and paper, this became a Pavlovian habit. It became a sort of a habit of mine that I always used to ask the patient, are you allergic to penicillin, before I prescribed them antibiotics. And obviously it's also important to know the difference between a true allergic reaction and a non-allergic reaction. Tip number 14 is related to antibiotics, and is related to young women or women of childbearing age. And again, this was an old habit of mine. Anytime you want to prescribe antibiotics for a young woman, always check to see if they're on the oral contraceptive pill, because antibiotics can interfere with that and reduce the efficacy of the OCP. So always check if a young woman or a woman of childbearing age is on the OCP before you prescribe them antibiotics. Tip number 15 is again kind of related, and if you're doing an intimate exam, or if you're doing an examination, even if it's just involving examining the abdomen or something like that, always have a chaperone. And the other habit of mine was always to get the chaperone to sign and date her name, and of course her, because it was always a female, a young nurse usually, and I used to get them to sign and date. I used to say chaperone present, and I used to ask them to sign and date it for the avoidance of doubt. Tip number 16 is about work ethic, I guess. Again, for a lot of you, this will be the first time you're in kind of consistent, long-term, serious, full-time employment, where, you would be missed if you're not there on time and so on. And the whole point of this is to be known as a reliable and consistent colleague, somebody who turns up on time, somebody who does a good handover, somebody who doesn't kind of leave work for other people to do. Medicine is not a 9-to-5 job, and it's kind of generally frowned upon to leave colleagues work to do that you should have done yourself. You don't dump on your colleagues. The reverse is also true. So, for example, if you have a cheeky afternoon off, instead of just disappearing, always just double check with your colleagues, your peers, to see if they're being snowed under and if there's something you can do to help, or to lighten their load in some way. If there's some sort of gap in your day, if there's a 15-20 minute gap, see if you can kind of do a bit of tidying up the office that you'll share. If you're a reliable colleague, if you're not a Jobsworth, if you put out some good vibes into the world, some positive energy, and actually are kind of prepared to do a little bit for somebody else, that will rebound on yourself multiple times over, and people will be able to cut you some slack. There'll be a fund of goodwill. So always remember, as a junior doctor on day one, you start with a sort of fund of goodwill, and your job is to constantly add to that and not to constantly draw on it, and certainly not to go into the red, not to go into overdraft, because then people will not give you the benefit of the doubt and will not cut you any slack, when inevitably you will need that at some stage. Tip number 17 is to look after your physical health. Wear comfortable shoes. Make sure you get adequate fluids in. I remember when I first started in August of 2003, it was actually at that time, it was the hottest weekend ever on record in the UK. Now, these things come around very much more frequently now because of climate change, but at that time it was a very, very unusual thing. Temperatures that weekend, the first weekend on call, I remember, reached something like 37, 38 degrees. And the hospital I was at, which was the Royal London Hospital, this is the old version of the Royal London Hospital in East End of London, was an old Victorian hospital with not great air conditioning, creaky floorboards and so on. And it was a horrific time. And I remember I actually had renal colic. I was so dehydrated. I had renal colic and I had blisters on my feet. So wear comfortable shoes, make sure you drink plenty of fluids, make sure you look after yourself. Tip number 18 is about referrals. So doctors ask other doctors to see patients all the time. There's inter-professional communication, and there are some unspoken rules and some spoken rules about these things. So one of the unspoken rules is the use of professional courtesy, for example. It's always nice to have a degree of professional courtesy if you're referring patients to each other. Of course, referrals can be verbal over the phone or written. And the way to make your own life easy about referrals, if you want to ask another colleague to see a patient, or if you're requesting a scan or something like that. So for example, if you want to go up to a radiologist as a FY1 and request a CT scan, always think, what do they want to hear? Always think, what is the buzzwords they'll be listening out for? What is it that they will sort of tip their decision from no to, okay, I'm listening, to yes. The other thing is, of course, it's useful to know what other specialties do, what they don't do. So this is a bit sort of close to home for me, the difference between maxillofacial surgery, plastic surgery and ENT. Know which department does what and for what reason. The other thing is also very important, especially if you're using written communication, is to the importance of words. Words should be used with precision and with care. So just to give you an example, the difference between facial surgery, plastic surgery and cosmetic surgery, they're not the same. So at sort of drive-by speed, they sound similar, but they're not the same. So always use words with intention, I guess, with being intentional with the use of words. And again, on that and on a related note, it's always good and very impressive to use good, correct English. I used to teach English to speakers of other languages when I was a student to earn some money. And I have a particular sort of thing about this. It's always important to use good English, especially if it's written. So know the difference, for example, between less and fewer. Know the difference between patients without an apostrophe, patients with an apostrophe before the S, and patients with an apostrophe after the S. So, I always personally find if somebody has taken the trouble of writing a good, correct letter with all the right information, then you're liable to take them much more seriously, and again to cut them a bit more slack and give them the benefit of the doubt and view their application or view their request much more favorably. Tip number 19 is about consent. Now, very junior colleagues are not often required or requested to consent patients for surgery. However, sometimes you may need to do that, but also in your general everyday life, you'll be consenting patients for various procedures that you'll be doing. So another one of my little rules for myself was every time I wanted to consent a patient, especially if I didn't know the patient, I used to go back and retrace the patient's journey back to the original referral from the GP, to the clinic letter or anything on the computer or the clinic notes, to any pathology or x-ray or any scans, to the sort of theatre list. So everything kind of matched up and there was no discrepancy. That make sure that it was the right side. To also, when I was talking to the patient, to avoid sort of abbreviations, to sort of couch the consent in language that would be first understandable to the patient but also relevant to them. So an example of this would be if you say damage to a certain nerve, damage to the inferior alveolar nerve, for example, is different to saying numbness of the lower lip, which is the same thing, but one of them is couched in medical jargon language from the surgeon's point of view. The other one is what the patient will feel and experience. So I always put what the patient experienced in the consent form, because then you can say, well, I told the patient not just what would happen, but also what impact you would have on them. Tip number 20 is look after the NHS. Now, as doctors in the NHS in the UK, we are custodians of public money. This is taxpayers' money that is being spent on scans and blood tests and various other things. So always be very judicious and very intentional in your use of these things, because they cost money. And with all due respect to our friends and colleagues in the United States and other countries with a similar system, we really don't want to end up like that, because there are all sorts of perverse incentives that are built into the system that we really don't want to import here. So always think about the NHS and the fact that you're sort of a gatekeeper to taxpayers' money, even as a very junior doctor when you request a CT scan. In America, for example, the tendency, and again, this is a gross generalization, and if you're an American doctor and you disagree with this, let me know in the comments below, but they tend to over-investigate everything. They tend to over-treat everything, partly because they practice what we regard as defensive medicine, because they don't want to be sued and avoid litigation. So to give you an example of this, in America, quite often when they do a colonoscopy, they go all the way around to the terminal ileum and do a small biopsy of the terminal ileum, just to prove, if there was a litigation, that they've been all the way around the colon. Now, that's not unreasonable, but again, the more you do that, the more you introduce risk of potential complications and perforations and what have you. And quite often you may not necessarily need to do that, but they feel they have to do that because the system has those incentives built into it. There's a lovely word, telos, which is a Greek word, which I really like. And telos basically means sort of the purpose of something or the end goal of something. And, the purpose of medicine, the telos of medicine, in my view, should not be to maximize shareholder value. It should be to, help patients, to alleviate sickness, to improve society. And we all have a sort of share in that. And also, medicine doesn't really lend itself very well to market forces. So always remember, as a junior doctor within the UK's NHS, you are a custodian of public money, and it's something that is worth preserving. Well, as a thank you for staying to the bitter end, another tip I would share, a bonus tip, would be to look after your own mental health. So I mentioned earlier to look after your physical health with comfy shoes and what have you, but also it's important to remember your own psychology. Now, personally, I think a lot of this stuff societally and generally speaking about mental health is a bit overdone. I think we keep going on about it too much. And if you keep going on about something too much, if you're constantly ruminating on something, if you're constantly scanning the horizon for triggers and threats and so on, these things have a habit of becoming a self-fulfilling prophecy. So I think a lot of that is overdone, unfortunately, in our society. However, it's important to realize that transitioning to becoming a junior doctor from a student is actually quite a change. It's quite a challenge. It's a bit of it can feel like an onslaught, and it can feel a bit overwhelming. And the way I thought about stuff like this, and the way I think about it now even more, is not to kind of catastrophize and not to kind of pathologize the normal, because everybody feels anxious. Everybody feels overwhelmed at times, everybody feels frustrated and tired at times, and it's not the end of the world. And the most useful way I've learned about stuff like this is the concept of cognitive behavior therapy, and particularly CBT for yourself, because the word therapy implies that you go to a therapist and so on. There's nothing wrong with that, but the concept of self-CBT is actually very useful, and it's not about kind of having a therapist, it's actually about recognizing unhelpful patterns of thinking, what they call cognitive distortions, and kind of recognizing that in yourself and reframing a challenge, a problem, or an issue in the correct way. So to give you an example, one of the things that self-CBT does for your cognitive behavior therapy talks about is the notion of catastrophizing. Not every problem is a major disaster. Not every storm is a hurricane. It can be just a passing squall. Another one is what they call emotional reasoning, which is, basing your thoughts on your feelings. In other words, if I feel scared, therefore this must be a scary situation. Well, it may or may not be. You have to look for evidence of that. A good example of this is when the CBT helps people with fear of flying. Obviously people who are afraid of flying feel anxious and stressed and scared when they're sitting in an airplane, but that's what they feel. The evidence is that it's not really a scary situation because thousands of other people do it. You can too, in other words. Another example of a cognitive distortion, or an example of an unhelpful thinking pattern, is what they call dichotomous thinking. In other words, this dumb binary of it's either this or that. Medicine is actually full of shades of grey. It's very probabilistic. On the one hand this, on the one hand the other, risks versus benefit. We err on the side of this because of the sort of benefits outweighing the risks, and so on and so forth. So what they call dichotomous thinking, or black and white thinking, can be a bit of a problem when you're dealing with human beings who are complex, and medicine is complex. So as a new doctor, my advice would be to, when you find yourself outside your comfort zone, as I assure you, you will, almost on a daily basis, certainly initially, is to think about these things and actually to learn about CBT for yourself. Invest in a good book, a simple book that summarizes the details, and actually find a way to kind of be on the lookout for these patterns of thinking for yourself and to reframe them. And then you'll find that you become a lot less anxious, a lot more you feel a lot more in control, and then you'll find that you become a lot more anti-fragile. Anti-fragile is a lovely word that was coined by a chap called Nassim Taleb, who wrote a book about it. And essentially it means it's more than resilience. In other words, you become stronger with adversity. You become stronger as a result of a challenge. It's a bit like your immune system. So your aim should be to become anti-fragile in your work as a doctor, because challenges never end. Being outside your comfort zone never really ends, even for somebody who's been doing it for a long time. And so it's a really useful way of framing all this stuff and learning about it and making your own lives easier. Well, thank you very much for staying to the end. I really appreciate your time and attention. If you feel you got value out of this video, I'd really appreciate it if you can give it a thumbs up. The button is down there somewhere, and also to consider subscribing to my channel. It will help your colleagues and peers hopefully find the channel, and for it to be of use to them too. I'll see you on the next one.